Hi, this is Erin, your friendly ER educator, and I wanted to welcome you to another wonderful educational opportunity on ESI Triage. Just a quick disclaimer, all educational material should be used in accordance with your service's pre-hospital or hospital patient care guidelines and by the approval of your medical director. Nothing should be considered expert medical advice. The resources and information in this presentation are for continuing education and training purposes. Parts of this training are specific to Westfields Hospital and may not be applicable for your facility. If you are not in the service area that receives medical direction from health partners, you must treat patients in according to your medical direction and EMS hospital policies. The objectives of the course is really to understand the role of the triage nurse, review why it's important to accurately assign the appropriate triage level, review the ESI triage algorithm levels 1 through 5 in terms of severity, changes in vital signs that could be problematic, and looking at resources. We want to determine immediate life-saving interventions, review the interventions that could constitute a resource, understand what patients' conditions might be red flags that could trigger a higher ESI level rating, look at some common triage pitfalls, review some patient examples and rationale for the ESI level assigned, and then practice ESI designation with patient examples and case studies provided on the worksheet. In order to obtain credit for this activity, you have to complete the presentation, take some time to reflect, and then fill out the activity worksheet with the post-test and turn it in to the department educator with your completed competency form. We're first going to start off when looking at the history of triage. Triage actually comes from a French word meaning to sort. It was initially used as a term for sorting coffee beans. That's right, little fun fact for you. The earliest forms of triage were developed around the 1700s, were trauma-focused, and they were developed for mass casualty incidents during wartime. During times of war, patients presenting to medical staff were often categorized as immediate, urgent, and non-urgent. Does this sound like any other form of triage that you might know? If you're thinking start triage, you're correct. In 1999, the Emergency Severity Index was developed, and data shows it's currently being used in 94% of the ERs in the US. And ESI triage is currently recommended by ENA and the American College of Emergency Physicians as the go-to way to triage patients. So what is triage? What is the role of the triage nurse, and why is it important to be accurate? When I was a brand new baby nurse in the ER, I took a triage class from the ever-famous Sandra Fonkert, a nurse with 40 plus years of emergency room experience, and she always said triage is a process, not a place, and it can be completed anywhere. And that's so accurate. You don't have to be in rooms 1 or 2. You can really triage anywhere as long as you follow the algorithm. You're really just sitting there trying to figure out, is this patient sick or are they not sick? Do they need help? Do they not need help? Can they wait a little bit? Can they not wait? Right? So triage is the sorting of patients, which helps us determine the priority in which patients are seen by the provider. Appropriate triage helps staff identify what patients can safely wait in the lobby versus those that need immediate intervention. Triage is a vital step in the care process as it helps provide the correct resources for the correct patient at the correct time. Accurate triage helps us allocate staff to ensure the highest level of appropriate care is available to each patient. And when done correctly, triage can reduce patient mortality and morbidity. It is super important that we get this correct. And I'm not saying that we need to have the correct number on the correct patient every single time, because we all know that things can change, right? Throughout the course of the patient's stay, but we're going to talk about that in a little bit. What I'm saying is that you need to be able to use the process and identify which patients are sick and which ones aren't sick, and which ones can wait and which ones need that last bed, so that we are caring for the patients that are sicker in a timely manner. Let's take a look at the ESI triage algorithm. ESI is a 5-level algorithm system to help facilitate triage, and the picture that I've included here is actually the version 5, which just came out last year in 2023. Not really any big changes. Most of them are pediatric related, but we'll touch on that. In theory, triage should take about 5 to 7 minutes to complete. As you get more experienced, you kind of get this spidey sense, right, of like, Is this patient sick or are they not sick? You can kind of do that across the room assessment and really get an idea of, does this person have some life-threatening intervention or problem that we need to address right away? Is something off with their presentation? Are their vital signs abnormal? So you really shouldn't be taking a half an hour to triage your patient. You should be doing this in a few minutes. And the ESI triage is used at the time of ER presentation. That's super important, right? It's at the time of ER presentation. The ESI number should not change after initial designation. However, the patient's condition might worsen or improve, but the ESI designation should not change after initial designation. I will say though, if you have a patient and you initially triage them, and maybe there are 4, and we happen to be full and they're sitting out in the lobby, if their condition changes, you can change your ESI all the way up to the point until that patient sees the provider. And we'll talk about why we shouldn't change it after we see the provider. But if you're going throughout the triage process and the patient conditions changes after they've been triaged before they're seeing a provider, it can be changed. However, it should not be changed based upon the provider or based upon, if the patient's condition gets better or worse after interventions. It's really that initial presentation. There are 4 conceptual decision points using ESI algorithm to determine an acuity level. First, is this patient unstable and in need of immediate life-saving interventions? Yes, then that patient should be a number 1. And we'll talk about all the different numbers, and I'll give you some patient examples and situations where you would want to delegate 1, 2, 3, 4, or 5. Then if the patient, if the patient requires life-saving interventions, they're a number 1. If they don't, is it a high-risk situation? Are they confused? Are they in severe pain? Are they in distress? Are there changes in vital signs? If that answer is yes, then they should be a 2. If that answer is no, then you need to look at how many resources they will need. If they don't need any resources, that's a 5. If they need 1 resource, that's a 4. If they need many resources, that's a 3. Now, one thing you need to do and look at this is, are there any high-risk vital signs? Are there any abnormalities in pulse, blood pressure? And it needs to be patient-specific, right? So like a patient who is having an anxiety attack, obviously they're going to be tachycardic and tachypnic. So make sure it fits the clinical presentation. But are there any high-risk vital signs? Are they hypotensive or hypertensive and their clinical picture fits? Is there a pediatric patient? Do they have a fever? Are they an oncology patient? Do they have a fever? Really look at the vital signs and does it make sense with the presentation. If any of the vital signs are high risk, you should consider elevating their ESI level, even if you don't think that they're going to need a bunch of resources. And we'll give some examples in just a moment. This slide is just showing a detailed ESI triage algorithm. So it's got the algorithm and it breaks down kind of each step and explains them a little more. We're going to go into detail with this, but this resource is also going to be included in the ESI binder that hangs out at the nurse's station up with all the other binders. If you ever want to reference the detailed algorithm and then the new version 5 ESI triage book. So before we get into the levels, I just want to touch on what is considered a resource. Resources are interventions, labs, imaging, procedures, etc. So examples of resources could be labs, blood, urine, etc. If you have multiple labs, like if you're going to draw blood on someone and you're going to get a urine, labs is considered one resource. An EKG, CT scan, X-ray, MRI. Again, if you're going to get a CT scan and an ultrasound or a CT scan and an X-ray, it's considered one imaging study. So just think of your studies, your multiple studies, under umbrellas, like the lab umbrella or imaging umbrella, etc. IV fluids are considered a resource. IV, IM, or nebulized medications are considered a resource. Specialty consultation is considered a resource. A simple procedure like a Foley or a lac repair is considered a resource. And complex procedures such as procedural sedation, so maybe you have to reset a joint or cast someone or do a lac repair with sedation on a kiddo or something. That's considered 2 resources, so keep that in mind. Things that are not resources: a history and physical exam by the physician, point of care testing, which we don't really do a whole lot of, but things like a blood sugar check, a saline or a heparin lock. So just putting the IV in is not considered a resource. You have to run something through it. Oral medications, not a resource. A tetanus shot, not a resource. A prescription refill. A phone call to a primary care physician. Simple wound care, such as redressing a wound, not a resource. And then ortho devices are also not resources. All right, so let's break down the different levels of ESI. And I'm going to kind of break them all down into, are they stable, unstable? How many resources do they need? And can they wait or can they not wait? And then I'm going to give you some examples. So when we look at ESI level 1, this is really a threat to ABCs, okay? A threat to ABCs. So when we look at airway and breathing, this is emergent CPAP BiPAP. This is a patient who's getting vague valve respirations or ventilations. This is a patient who's intubated. If they're unresponsive and unable to protect their airway, someone who might need a surgical airway or they have airway obstruction. When you look at circulation, it's a patient who's getting CPR. Maybe they're cardioverting. I know we don't often put them as a level 1, but they should be. Cardioversion, if we're going to defibrillate someone, a patient who needs pacing, chest needle decompression for a tension pneumo or thoracotomy, control of major bleeding, someone who's getting an IO or they're getting significant fluid resuscitation. Medications that qualify your patient to be an ESI level 1, massive blood administration. Anytime you give atropine, dopamine, Levophed, Epi, Narcan, adenosine, and certain situations like D50, and we'll talk about that in a second. But ESI level 1 is often under triage. You know, we always typically go for like your cardiac arrest patients, a level 1. But really think about anything that is a threat to ABCs. Some other examples of patients that are ESI level 1s: penetrating trauma to the head, neck, or chest, and if they are unstable hemodynamically, respiratory distress or arrest, critically ill or injured trauma patient, an overdose, again they might have to intubate, severe bradycardia, tachycardia, or chest pain with signs of hypoperfusion, sepsis with signs of hypoperfusion, which again we often don't put them as a level 1. They're probably level 2 in most of our triages. An anaphylactic patient is certainly a threat to ABCs. A flaccid pediatric patient, and we'll hit on peds in a little bit. And then your unresponsive patients, potentially your alcohol, head injury, drug use, overdose, hypoglycemic, septic, etc., especially those ones that can't protect their airway. So if you have a threat to ABCs of any kind, these are patients that are going to need life-saving resources, multiple resources, probably multiple staff are going to need to take care of these patients. And these are obviously patients that cannot wait. You should not triage them and send them back out to the lobby. These are pretty sick and severely ill patients. All right, ESI level 2. So really these patients could be stable or unstable. They're going to require many resources. Again, they might require many staff. If you think about, can this patient wait or not wait, they really shouldn't be waiting longer than 10 minutes to see a provider. And then if they can wait, are they potentially high risk? Are they potentially unstable? Or do they have any abnormal vital signs? I included the high risk vital signs based on age on this slide. And again, making sure that the clinical picture fits, right? So you could have an anxiety patient that's tachycardic and tachypneic, but does it make sense clinically? And then really looking at those pediatric vital signs too, because that's where we're going to run into those higher risk situations. Some examples of ESI level 2 are on the right-hand side here. A lot of these, could potentially be a concern for level 1 if the patient is not hemodynamically stable. If they are hemodynamically stable, they're probably going to be a level 2. So respiratory distress, an asthma attack, a STEMI with active chest pain, but they're stable, stable sepsis, a stroke without airway compromised, a patient who's confused, disoriented, lethargic, altered mental status, and we don't know why. That could be an ESI level 2. An amputation, compartment syndrome, certain fractures could be a level 2, especially if they're circulatory compromise. Looking at reproductive, there could certainly be some pregnancy presentations that could be at level 2. We look at burns, abnormal rashes, your endocrine patients like your DKA and HHSers, certain ocular injuries, think of like a globe rupture or something like that. Mental health, your suicidal, homicidal, overdose patients should always be level 2. Domestic assault, sex assault, again, many resources. You might need multiple staff taking care of these patients. And when you're considering domestic assault, sexual assault, they could be a level 2 for security reasons. They could be a level 2 if they're unstable due to trauma. But certainly the suicidal, homicidal, and overdose should always be a level 2. Other things where we don't necessarily make them a level 2 always is that severe pain and distress, right? We know that pain is subjective. But usually if they're saying that the pain is greater than 7 out of 10, you should consider increasing their ESI level. And we all know that certain patients look worse than others, and my 10 is not the same as your 10. But that's something to consider if they are in a significant amount of pain and distress, that their ESI level should be higher. Pediatric fever, and again, we're looking at those high-risk vital signs. Respiratory distress, dehydration, DKA, child abuse, possible head trauma, could be a level 2, especially in the peds population. And then other kind of interesting patient presentations could be a level 2. These could be like your oncology patients who are currently in treatment and they present with a fever greater than 100.4. That's a medical emergency. A needle stick by a healthcare worker could potentially be a level 2 and should be categorized as such. And then I also think about our transplant patients, because they are multiple resources, multiple comorbidities. So also keep that in mind. Your patient, it's never what they just present with, right? It's never just constipation. It's never just I can't pee. Usually there's other comorbidities, other considerations to keep, in the back of your mind when you're thinking about what's this triage going to be? What are my resources going to look like? How many images, how many labs, how many other things am I going to potentially do for this patient based on their presentation and their history? So keep that in mind. ESI level 2 is often the most underutilized and under triaged level that we have between level 2 and level 3. And we really should be triaging more level 2s, not only for billing purposes and letting others in the hospital, our leaders and stuff, know that we're actually caring for these patients, but it's super important that we're letting them know that we're caring for these higher acuity patients, because in a little ER like ours, it really sucks up our resources sometimes. And so we need to get credit for the work that we're doing with these higher acuity patients. ESI level 3. So this is most of our ER patients, to be quite honest, right? And so is level 4, but most of our patients in Westfields are ESI level 3. These patients are going to be stable. They may or may not have many resources, right? But at least 2. And then, if they had to go back out to the lobby, they really shouldn't be waiting more than an hour. Examples of your ESI level 3 would be abdominal pain, but they should be vitally stable, chest pain that are not level 1s or level 2s, complicated UTIs, kidney stones, DVT without ABC compromise, nausea, vomiting, where we're not concerned about circulatory compromise or dehydration. Certain dysrhythmias, I'm thinking like a PAC or a PVC, and they're vitally stable. And then most of your ortho injuries, maybe ones that need some sedation or stabilization prior to them going into an ortho device or something like that. Your run-of-the-mill patients are going to be your ESI level 3 patients, where they're going to need some interventions, they're going to need some resources to figure out what's going on with them. Maybe that's imaging or labs or something like that. You know, most of our patients are going to fit this category, where we're going to need to figure out, do some IV, do some labs, do some fluids, do some imaging, figure out what's wrong with them, and then provide appropriate interventions. ESI level 4, again, this is going to be most of our ER patients. They're going to be stable, they're going to use one resource, and really they can wait. If you had a full ER, these patients can wait. Examples of a level 4 would be a tetanus or other immunization. It's listed that a tetanus is not considered a resource, but most of the time a patient's not coming to the ER for a tetanus shot. If they are, it's going to be a nurse-only visit. Oftentimes they're coming in because they have a lac repair and they need a tetanus shot. So then you're looking at 1 for the lac repair. Catheter placement, a lac repair, sprained ankle who might need some x-rays, a simple fracture that's going to need an x-ray and maybe an ortho appliance, someone who wants a COVID swab, you know, like, oh, I need to know what my COVID status before I go to work. An uncomplicated UTI where they're probably going to get oral antibiotics and go home versus IV antibiotics. You know, there's a bajillion ESI level 4 patients, and just kind of looking at resources, you know, just consider, you know, how many resources you're going to need for this patient. Do you think the doc is going to want to do any more interventions or looking at imaging or labs or anything like that? If you don't think it's going to be a complicated thing, your patient's probably going to be at ESI level 4. And, you know, if there are other patients in the hospital or ER that are sicker, the doc's probably going to see them first. Lastly, ESI level 5, these patients are stable. They're not going to require any resources and they can wait. And really, our ESI level 5 patients are probably more appropriate for the primary care or urgent care, but hey, we're happy to see them in the ER anytime. Examples of level 5s, medication refills, a nurse-only visit, some simple wound care, maybe somebody who's having like ear pain and so they're getting a history and physical with oral antibiotics. So, you know, a mom brings their kid in with you know, ear pain, the baby's tugging at the ears, the doc does an ear exam. Oh, yep, you have an ear infection, here's some oral antibiotics. That's a level 5, right? So these patients don't need a whole lot. Other things would be like a nurse-only visit. Maybe they need a wound changed, or they need their PICC line dressing changed, or they need their catheter flushed, stuff like that. Or a patient maybe needs, you know, it's the weekend and they need their medication refilled. Lots of things can be an ESI level 5. If they're not going to take up resources, they should be a level 5. And again, these patients can wait. They're stable. I want to touch on some triage red flags. So when you're doing your triage and you're screening these patients, and then you start to either see or hear any of these presentation statements, this might have you increase your level of ESI triage. And this is not at all by all, you know, an all-inclusive list. So keep that in mind. These are just some things that, you know, if you hear some of these things or see some of these things, you should consider upping your triage. So first one, acute or sudden onset. An acute change or sudden onset is different than a chronic expectation of a normal disease process. If you have a COPD patient who is always short of breath, right, that's a chronic and expected finding of the disease process. But if you have a patient, maybe they were, you know, they just got off a flight back from England and they were walking through the airport and all of a sudden got acute, sudden onset, terrible chest pain, and this is brand new and it hurts and, you know, they're really short of breath and this just happened, you know, that would be a bigger red flag than the COPD patient with shortness of breath, because that's an expected finding. So is this an acute sudden onset finding? That would perk my suspicion a little bit more. Uncontrolled hemorrhage, that obviously needs a higher ESI, and that could potentially need some life-saving interventions. Hypotension or hypertension, and again, that has to fit the clinical picture. right? And this should be more than one value. We all know that people don't come into the emergency room on their best day. So if they're a little tachycardic and hypertensive, let them calm down a little bit, repeat the blood pressure, make some jokes, get them to relax a little bit, repeat that blood pressure. If there is sustained hypotension or sustained hypertension, then yeah, that absolutely is a threat to ABCs and we need to deal with that. Altered mental status, we hit on this a little bit, but why are they altered? Are they having some sort of mental health crisis? If so, they might need to be a level 2. Are they so altered that they can't protect their airway? Then they should be a level 1 and you need to consider intubation. Do they have a massive infection? Are they septic? Well, then you need to increase your level of triage there until you figure it out. Are they hypoglycemic or are they hyperglycemic? And that's why they're altered. Do they have a threat to ABCs? Is there an airway obstruction? Are they having accessory muscle use? Are they tachypneic, tachycardic? Are they cyanotic? Okay, also things to be like, oh, we need to intervene quickly here. If they have a non-blanchable rash, that is a red flag. Then you're starting to look at threats to circulation there too. Abnormal Perla, again, that's going to kind of go with altered mental status. But do they have a head bleed going on? Are they having a stroke? Then you need to increase your level of triage there. Hypoglycemia, hyperglycemia, we can often treat that, and that's where that D50 comes in when we learned from ESI level 1. And this is situational. But if they're really hypoglycemic or hyperglycemic, you might need to increase your level of triage. And then are they hypo or hyperthermic? And I'm thinking like sepsis. Is this a patient that we need to potentially see quicker? And I will tell you, some of the worst septic patients I've ever seen are actually hypothermic. So keep that in mind. And then think about your pediatric patients too. So when you're looking at some of these red flags, if you start to hear some of these things or you're seeing some of these things, you might need to consider that they need to be seen more quickly than others. Okay, I want to address some common pitfalls in triage. So let's talk about mistriaging first. Mistriage occurs approximately 30% of the time. That's a lot. Over-triaging, this can lead to providing extra resources at the expense of another patient. So let's say you over-triage your patient and you're providing all these resources and they don't truly need it. That could be taking you away from another patient who does need it. Under-triaging, which happens a lot. And I'll talk about this in just a second, but typically this can be seen in busy departments where there's a lack of space, lack of staff, lack of resources, etc. And like I mentioned earlier, the most common under triage is between 2 and 3. And the other thing with under triaging, I feel like in my own experience, and I'm sure some of you feel the same way, that you just get used to seeing sick patients all the time, and so maybe your radar for how a patient is actually sick might not be accurate when you're just following the algorithm. So like when I was at the U, all those patients were sick all the time. The admission rate was just absolutely ridiculous. And I'm sure some of you who worked at Regions felt the same way, right? These chronically ill people, they're always chronically ill. We're always seeing these really sick patients, and you kind of just don't have sensitivity is not the right word, but you just don't have that internal freak out with these patients because they're always sick, right? So you're like, oh, they're stable, they're a 3, whatever. When they really are, vital signs might be off, they might have some of those red flags, they might need multiple resources, and they really should be a level 2, especially if they're an at-risk patient or an at-risk population, like our oncology patients or something. So, really just follow the algorithm and, just kind of keep it less subjective. Just really use that objective data to kind of drive your triaging. This one I'm not very good at myself, you guys, so don't get on me about this one, and I'm sure you guys all know who I'm talking about. But resources should not be provider dependent. I know I have personally worked with physicians, as I'm sure all of you have, and you're like, well, this patient should be a 4, but considering the doc that's on, we're going to make them a 2 or 3 because we know we're going to do a ton of interventions and we're going to do a ton of resources, right? Everyone's going to get lined in lab. They're all going to be worked up for sepsis. But really, resources should not be provider dependent. And if you're finding that you are triaging appropriately and then the provider is ordering a ton of things, that's something that really our leaders should be looking at. So this isn't really something that we should worry about. We should continue to triage appropriately. And if the providers are ordering more, then that's on them. And maybe that's something that should be brought up to the leaders. Another thing is triage accuracy can be affected by the time restraints with patients. If you are a busy ER, you might not triage appropriately because you don't have the space to put these patients. So you're going to triage a little bit lower. Based upon the level of experience of the triage nurse, your triaging might be inaccurate. And that's okay. It takes time as long as you recognize when someone is sick or not sick. Because it's really important that we get those sick patients back. And we also need to recognize that if they're not sick, it's okay for them to wait in the lobby. It really is. We don't have to have the mentality of bringing every patient back as soon as they walk in. If they are not sick, or if, sick or not sick, if they're not that sick and they don't have a high acuity, it's okay to make them wait. As long as there isn't some glaring problem looking at you, as long as their vital signs are fine, as long as they're stable, they can wait, right? They've been waiting at home, so they can wait a little bit longer until you have the appropriate room and, your staffing is appropriate. Obviously, if they're unstable at any time, they need to come back right away. But please don't feel like they have to come back. Another thing that can lead to pitfalls in triage is when a provider or a nurse has some implicit biases that can affect the provider's perception of the patient, right? And I hate to say it, I've done this a million times myself, but we all have biases, and we're going to do another education on that, but everybody has biases. And this can kind of cloud our judgment and not actually look at our patient for the concerns that they're having. This happens a lot when we see patients that are coming back for the same issue multiple times in a row, and we kind of get numb to the fact that maybe something new could be going on here. And I will just share with you a little story here. When I was a brand new baby nurse, I had a patient who used to come in pretty frequently for abdominal pain, knew that they could get narcotics because of abdominal pain, and he had come in multiple times and had just come in overnight. I came in and worked 7 a.m. to 3 p.m. and this particular patient had just come back, and the night nurses were telling me, oh, this patient was here multiple times throughout the night, whatever. We worked him up. We couldn't find anything wrong. He's probably just wanting narcotics. He's probably just wanting some turkey sandwich or whatever. He can go back out to triage. So I triaged him, and I noticed that he was hypotensive and tachycardic. He was complaining of abdominal pain. I lifted up his shirt to do an exam and have him show me where his belly pain was, and he had bruising all across his abdomen. And I asked him, I said, so what brings you in with this abdominal pain today? And he goes, well, I was just riding the light rail overnight because it's a warm place, right? And so he was riding the light rail back and forth between Minneapolis and St. Paul. And he was assaulted on the light rail, just beat to crap with a baseball bat. And so he had come in multiple times for abdominal pain, and they kind of just were like, oh God, this guy's back again. Out he goes to the lobby, and no one really took the time to ask the questions. And things got missed. And he ended up having a retroperitoneal bleed, and then damage to his kidneys because he was beaten with a baseball bat, and he went to surgery. So sometimes a fresh set of eyes is really important, especially if you have a patient who is coming in frequently. Have somebody else triage them. Get a fresh set of eyes on them. I think we are all just like, oh, I've had this patient, I'll go see them, or I'll take this patient. Sometimes a fresh set of eyes can be really helpful, especially if you're having kind of a negative perception of the patient. Other pitfalls in triage, when there can be delays in triage, patient care can be detrimental. And really, if you have a delay in triage, it can be significantly detrimental to patient outcomes, right? Because if you're not triaging them appropriately, you could be missing those life-threatening things, and it's just a delay of care. If you have a patient that is complaining of pain, and this is true for any type of triage, but if you have a patient complaining of pain, make sure that you use subjective and objective data. And then lastly, just remember your final disposition does not equal their presenting acuity. So if you have a patient who comes in and maybe they twisted their ankle, and you triage them as a level 4, maybe they're going to do an x-ray or whatever. Well, you get in and you do your x-ray and you find out, say this is a kid, and then you find out they're going to need some sedation to do a reduction, and then they're going to need an ortho appliance, and then because it's bad enough, they're going to transfer to children's, right? So please don't feel like, you have a magic crystal ball and you're trying to figure out what their final disposition is. That's not what's going to ultimately affect your acuity. You need to just triage them based on their presenting acuity. And like I said, if their condition changes, so be it. But that is their initial presentation to you in the emergency room. It's not what the whole course of their ER stay is going to look like. All right? All right, so when you're triaging, make sure you're asking all the questions. Just kind of think to yourself, and some of this will come with time and experience if you're a new nurse, but you always ask yourself, what is the worst case scenario for this patient, right? I always say ER nurses are positively pessimistic. We're always prepared for the worst case scenario, right? Hope for the best, but expect the worst. Same thing, like what's the worst case scenario for this patient? If we don't intervene, what's the worst case scenario for this patient? Ask appropriate and focused questions to figure out what brings you to the ER today. There are some patients, we've all heard them, right? And they will tell you their entire life story. And it's like, okay, that's great, but what brings you to the ER today? What is different today? What was so bad today that brought you in? What's worse today? Really get in on those focused questions. Use your sample history and your OPQRST to guide your questions. And then again, as we talked about earlier, is this a new acute onset problem, or is this an expected finding, which is, related to their chronic problem or related to other comorbidities, right? Are their symptoms expected or not expected for that disease process? Can they wait? Are they at risk for deteriorating if they wait? If not, they need to come back sooner, higher acuity level. And then what does your gut say? Are they sick or not sick? As you get more experience, you'll be able to kind of use your spidey sense and figure this out. Are they sick or are they not sick? Use your experience and intuition, and if something doesn't feel right, escalate your concerns. No one's ever going to fault you for advocating for your patient. All right, I want to touch on some undertreated and vulnerable populations. So I put on some normal vital signs for your pediatric population, and then some pediatric temperature red flags, especially for those newborns, and then patients that are 3 months or older. But undertreated and vulnerable populations coming into triage, definitely your pediatric patients. You might need to use more of a pediatric assessment triangle for more accurate triaging, and this is really looking at sick or not sick. And if you haven't taken ENPC before, they're going to hit on this, but this is something to really consider. Focus on ABCs, your neuro exam, and a potential fever, especially in the infant. That's important. Know your pediatric vital signs, and again, I put this over here for your reference, and making sure that you're using appropriate pain scales. Don't ask a 1-month-old what their pain is on a 0 to 10 scale. They're not going to tell you. And there's plenty of pain scales like the FACES and the FLAC scale to be using for your pediatric patients, so you're getting an accurate subjective and objective response. Older adults are another vulnerable population. They may downplay their pain and symptoms thinking it's just a normal sign of aging. They might present with more non-specific or vague symptoms, and when you're hearing that or seeing that, assess further. Vital signs might be misinterpreted due to age-related changes. And another huge thing is be mindful of comorbidities with our older adults and polypharmacy that could be masking certain symptoms. You know, I'm thinking like your beta blockers that might mask your diabetes symptoms. So just be mindful of the fact that they're on a lot of meds that could potentially mask certain symptoms when we're looking at chief complaint. And like I said, if they're non-specific and vague and they're just not feeling well kind of thing, assess further and figure out what's going on. Mental health patients can also be a vulnerable population. Are they high risk? Do they have risk of harm to self and others? If so, they need to be a level 2. And then trauma. Trauma, making sure that we're following the TTA and TTA standby criteria. And then considering, do they have a high risk mechanism of injury? If so, level 2 or higher. And even without obvious signs of injury, consider potential problems based on your mechanism of injury, right? So even if they don't have obvious signs of injury, if they're in a high-speed car crash, you know, you need to consider all the what ifs and the possibilities. And you really need to consider, should they be at ESI 3, 2, or even a 1 based upon that mechanism of injury. So really looking at those TTA criteria. Okay, I am not going to read all of these for you. You guys can read on your own. What I do want you to do, though, is to use your triage knowledge that we've talked about. Use your ESI algorithm. Pull out your book. Google it. You're not going to be able to Google the questions because I made up all of them, but look for those triage pitfalls, the red flags, the change in vital signs. Look at the history and presentation. Look at the age of the patient. Look at their comorbidities, etc. So use all the things that we just talked about to try and figure out what ESI level these patients should be. On your worksheet, follow along and write in your triage number for all of the patients presented. So you can move through these, pause the presentation as you need, and move through them. You know, as you need to move through, if you need to take a pause or whatever, do that as you're moving through all these numbers. But again, write in your number and your answer on your worksheet. Here's your second group of questions, your third, fourth, fifth. So hopefully you've got all of these on your worksheet. If you really want to know the answers to these, if you're that kind of person, I have all of the answers with rationale, so please reach out and I can share that with you. And then last is my slide of resources. And if you have any questions, don't hesitate to reach out. I'm happy to run through anything with you or talk about any of the scenarios. If you have any questions whatsoever about the worksheet, let me know too. And then make sure that you review this, you go through the worksheet, and you turn it into your educator so you can get credit on your competencies. Hope you enjoyed the triage. Hopefully it was a nice review for you, and reach out with any questions.